Dear colleagues, I basically want to put the focus of my presentation onto the variability and differential diagnosis of vitreous floaters. I began offering laser vitreolysis to my patients in 2013. In Germany I was the first being observed with spectacism by many of my colleagues. Therefore I spent a lot of time and energy to produce media to teach and to share my knowledge. In particular I have put my main focus on utmost security measures. Even the German Ophthalmic Society has meanwhile accepted laser vitreolysis and has adapted the official guidelines for the treatment of vitreous floaters. YAG laser vitreolysis is now accepted for certain well-defined cases. The treatment decision is based on taking a comprehensive patient history, thorough clinical examination, realistic expectations, and detailed patient information including the risks of the procedure. In comparison to other ophthalmic YAG laser applications, YAG laser vitreolysis differs predominantly by its specific technical equipment requirements. In addition, treatment is more complex and time-consuming. It requires appropriate experience and knowledge of the surgeon. It should be carried out with utmost care and accuracy. This is a case of a myopic patient suffering from a giant vice ring floater. It is a really ideal indication for YAG laser vitreolysis. Patients are almost always free of symptoms after the treatment. But unfortunately the success rate overall is by far not as good in other cases. Please note that not all vitreous floater patients are candidates for the laser treatment. I got the chance to publish an article including a summary of the principles of YAG laser vitreolysis and a new classification of vitreous floaters in January 2019 in the Journal of the German Ophthalmic Society. Luckily the chairman of the ophthalmic university departments of Göttingen, Bonn, Rostock and Kiel were co-authors. This was very helpful to give this new procedure some credit. Manifestation of vitreous opacities and possible subjective impairments are considerably variable. Therefore not all vitreous opacities are suitable for laser treatment. A classification according to the histoanatomical origin of the vitreous floater material can aid the treatment decision and should be helpful for future research. All floaters which originate histoanatomically from the retina belong to the group 1. A classic example is an operculum from a round retinal hole. Patients are not often bothered by it. In case they do, treatment is possible. But as the operculum usually is far off the optical axis and access for the laser beam is technically difficult and might require contact lenses with prisms. This case shows the variability of vitreous floaters. We are looking at a giant floating cyst originating from the epithelium of the ciliary body which histoanatomically is group 1. Puncturing the cyst with the YAG laser to make it hopefully shrink might be an option as an alternative avoiding vitrectomy. The peripheral visual field of this desperate 40-year-old lady with retinitis pigmentosa is already very much impaired. The floating cyst even blocks her central field intermittently. Here you get to see 3 different vice ring formations which have been torturing the patients. They belong to the group 2 and originate histoanatomically from the detached posterior vitreous membrane. The prognosis for laser treatment is excellent in this group. This is a vice ring formation surrounded by a dense fibrosis of the posterior vitreous membrane. This ocular pathology can be observed quite often in combination with a macular pucker. It requires multiple laser sessions and a lot of laser energy. I recommend to perform them over a period of a few weeks with a constant focus on ocular pressure rises. Still remnants of the material will remain. You should consider to perform a vitrectomy primarily. This is a similar case, luckily less pronounced. The patient was quite young and decided to have a laser treatment done. But again, I recommend not to perform it in one session and please be prepared that the patient might get high ocular pressure rises. Luckily a good result without complications could be achieved, as you can see. When the patient presents for the first time, I usually perform a thorough clinical examination which includes movie clips of the floater. Here you see a spectacular movie of a floating vice ring. The diagnostic of floaters is by far not as easy as in these cases. It is very helpful and often essential to find the disturbing floater to make the patient look up and down or to give the eye a gentle kick with the contact lens. This makes the floaters move and you might find the one and only that is the disturbing problem. Now we are going to talk about Group 3 floaters. This group is unfortunately often very resistant to laser treatment. Those floaters are degenerative formations of the original framework of fine collagen fibrils. We find a huge variability of vitreous structures like cotton ball-like threads, clumps, clouds or bottlebrush formations. These are often just partially removable. Here you get to see a large floater cloud fixed on the optical axis. This type of Group 3 floater is very much debilitating the patient. He does not just suffer from the floater but from a permanent visual impairment as well. Removing it gave the patient a high degree of satisfaction, but just for a few days. These 3 follow-up scans within a few weeks reveal the reformation of a large bottlebrush floater in the periphery. YAG laser vitreolysis partially vaporized the floater material. But a huge part of it is just fragmented into numerous little pieces of collagen fibrils which unfortunately show the tendency to form new clumps like you have seen it in this case. To avoid this scenario of reforming clumps, I have successfully treated in this case just the little floater cloud and left the cobweb of floater strings. Every patient that presents to your floater clinic is different. Spend time for a thorough investigation and consider carefully which strategy for the treatment you want to follow. Please get acquainted with the basic physics of light and shadows. The wonderful textbook of John Karakoff is a treasure trove of information. The art of YAG laser floater treatment is not really just the shooting but to detect the floater which annoys the patients. Invest time to examine the patient thoroughly or you will fail. Here you can see the flight path in low altitude across the central retina with any eye movement. In motion rest of the eye the floater always returns to this position. The diagnostic in this case was difficult and really time-consuming. The treatment was even more difficult in particular as the clump was close to the retina and out of the optical axis. Luckily I was able to solve the case successfully. The desperate patient had several consultations before in different practices without a proper diagnosis. If you consider to offer vitreolysis treatments in your practice, you should know that this is not a quick and easy procedure to perform. Furthermore, you can easily traumatize the sensible ocular tissues. My speaking time in the course is restricted and I have to come to an end of Group 3 floaters. But please allow me one more spectacular case. This floater is almost a piece of art. It is not a joke, but its owner was a vitreous surgeon worried to have a vitrectomy done. Now I want to talk about Group 4 floaters. The floater material originates histoanatomically from the posterior lens capsule. On one hand they are almost always treatable, on the other they would not exist if YAG laser capsulotomies would be done with more care. Together with Dr. Tobias Neuhann from Munich, I have produced a teaching movie which we have posted at the website ifox.com. The movie shows step by step how to perform a perfect YAG capsulotomy, avoiding floaters or damages to the intraocular lens. We have even been granted the iFox Film Prize 2021 for this production. Finally, I will get to talk about the Group 5 in my floater classification. It is basically a dump for whatever vitreous opacity is left that does not fit into the histoanatomical classification. This is a spectacular image of a sunken capsular tension ring. These days you see frequently silicon oil bubbles. Silicon oil is used as a lubricant for syringes used for intravitreal injections. These oil bubbles can be very annoying to patients. You cannot remove them by YAG laser treatment. If you do, you create a kind of snowflake-like particles from the burned silicon oil. Asteroid hyalosis can be seen very often. If patients are suffering from it, vitrectomy is the only treatment option. Let me finish my presentation, and in particular the Group 5, with a spectacular case which you might have never seen before. We are looking at the left eye of a 22-year-old patient. She came for a second opinion and was complaining of a massive impairment of visual acuity. That young lady had already an appointment for a vitrectomy. This slitlamp image reveals the diagnosis of an ocular amyloidosis. Systemic amyloidosis could luckily be excluded. The amyloid material is very much concentrated in the posterior vitreous membrane. This might have been the reason for the posterior vitreous detachment, which you normally do not see in a 22-year-old. Here you see that the posterior vitreous membrane has lost its transparency, which is the reason for the massive visual impairment. To classify this case precisely, we have a mixture of group 2 because it is histoanatomically the posterior vitreous membrane, and amyloid, which belongs to group 5. To be able to better understand this unique case, I have built a 3D model. The posterior vitreous membrane is detached but still sticks to the optic nerve head. The central retina in the optos scan is hidden behind a curtain of amyloid. As said earlier, vitrectomy was already scheduled. The girl is just 22 years old. Aren't there alternatives, she asked me. My Dutch colleague Kees van der Wind has published a few cases where he has treated floater patients with gigantic vice rings with surrounding fibrous plates, which I have described earlier in my presentation. He did not vitreolyze the floater, but he did cut a hole into the posterior vitreous membrane to get the optical axis free. His technique is called laser T-membranotomy. I was kind of nervous when I did apply his technique for the very first time, in particular in such a young patient. This optos scan is proof the effectiveness of the laser T-membranotomy. I have split up this complex procedure into several sessions on 4 consecutive days. In total 10,000 millijoules of energy were necessary to succeed. This is almost 50 times the amount you need to perform a regular YAG capsulotomy. That is kind of risky, people might say. But isn't a vitrectomy in such a young one not even more risky? Now I am relieved to be able to tell you that after a period of 6 years no complications at all did arise. The young lady just recently sent me a note telling me that she was able to finish her university degree and could get her driving license. What message could be more satisfying and rewarding? It shows that investing time, care and doing some literature research if necessary can do almost wonders using the YAG laser. Difficult cases I schedule out of regular hours to have peace of mind to achieve perfection. How to achieve a perfect laser focus. All surgical lasers are by definition capable of causing damage to the eye. It is essential that their effects be limited to the therapeutic end desired and that accidental damage is not inflicted on the patient. Let us therefore review basic clinical optics. The mode of action of YAG laser treatment is to bring a large amount of energy into a tiny focus in a very short time. Power density of the laser at its focus becomes high enough so that electrons are ripped off atoms, causing ionization, which is called a plasma. This rapidly expands, causing an acoustic and shock wave which can disrupt tissue in the immediate neighborhood of the blast. Temperature rises to 4000 degrees Celsius in a tiny focus of 8 microns. Essential checkups are crucial before getting started with YAG laser treatment. It is really important to double-check all your laser adjustments before you start YAG laser treatment. In particular if you work in a department where the laser is used by different surgeons. Get used to start with the adjustment of the eyepieces appropriate to your refraction. If the adjustments do not match your refraction, your laser focus will easily damage the IOL and you will end up with pits in the lens. The patient will pay the price for unprofessional laser treatment. This is malpractice and should be avoided at any case. The next step is to check the off-axis position of your laser and to choose your preference. To be able to double-check your laser focus, please watch out for the targeting plate. It should be part of the equipment like halogen replacement light bulbs. Adjust it to the headrest. Now you have to check whether your slit lamp focus is in the same plane like the two red helium neon aiming beams and your infrared YAG laser treatment beam. We are now looking at the targeting plate through the YAG laser slit lamp. In this example, the slit lamp view is not in focus. Here you see the slit lamp view in perfect focus. Next step is to activate the laser. Here you can see two red targeting beams while the targeting plate is in focus. To not start because the laser not safe for treatment. Now you can see the red targeting beams in focus. But the slit lamp focus does not match the targeting beam focus. Again, to not start because the laser not safe for treatment. This shows a perfect alignment of the targeting beams and the slit lamp view in the same focal plane. The next step is to release a couple of laser shots. Ideally you find a laser puncture surrounded by a scented halo. The laser is perfectly adjusted to your eyes and is now ready and safe for treatment. In case that you find a laser puncture surrounded by a descented halo, your laser is again not ready for safe laser treatment and it should be urgently serviced. How to achieve a perfect setting for the laser treatment. All surgical lasers are by definition capable of causing damage to the eye. It is essential that their effects be limited to the therapeutic end desired and that accidental damage is not inflicted on the patient. Perfect topical anesthesia is necessary before you start the laser treatment. To achieve good results and to avoid complication like lens pitting during YAG laser treatment, it is essential to have the patient comfortably and stable seated. Therefore you should avoid unstable and uncomfortable position for small patients like in this case. A separate and easy to construct footrest is an affordable solution. Your local carpenter will for sure be pleased to help you. If the patient's head position is not fixated and constantly readjusted by an assistant, you will easily cause trauma and imperfect results. Same pads of soft tissue give comfort to the patient. Of course, the surgeon has to sit comfortable as well. This soft rubber arm rest is a perfect piece of equipment to give the surgeon stability during laser treatment. Haag Strite delivers exchange rubber pieces for the joystick which fit perfectly to this laser equipment as well and give you a better grip. A special high plus power anterior segment laser contact lens is inserted. It stabilizes the patient's eye and minimizes the possibility of pitting the IOL during YAG laser capsulotomy. The magnifying button in the center of the lens enhances visualization and allows a precise laser focus on the posterior capsule. We prefer contact lenses with a flange. This increases stability and therefore provide more safety. Dust and scratches are always a problem. I have randomly chosen the contact lenses to check them for surface quality. They were in use by several juniors in a teaching hospital. Never use anything like this for YAG laser vitriolysis. Dust and grease on contact lenses is a permanent problem. Just shortly after unwrapping this brand new lens, we find dust on the surface. These are our tools to remove dust. We use compressed air spray and the Harmer lens pen. The product works without having to use any wet or moist products and is easy to use. Hydrophilic jelly from polyacrylic acid is widely used for treatment lenses. Corneal edema often develops after a prolonged treatment time, which you will often need for YAG laser vitriolysis. To continue laser treatment in this corneal situation is dangerous. Viscoelastic substances used for intraocular surgery like sodium hyaluronate like Helan or others are absolutely ideal for YAG laser treatment. You will never see corneal edema and patients feel postoperatively less irritation. Develop a technique to fill the contact lens cup bubble-free. Air bubbles will disperse your observation as well as the treatment beam. Following these guidelines will help you to achieve better treatment results. Thank you very much for your kind interest.